Morning, everybody, and welcome to Breast Cancer 101. I'm Dr. Hallie Moore. I'm a medical oncologist and director of breast medical oncology at the Cleveland Clinic Taussig Cancer Institute. And I'm also co-director of our comprehensive breast cancer program here at the Cleveland Clinic. My co-host tonight is Dr. Stephanie Valente, a breast surgeon who is the director of the Western Region Breast and Fairview Hospital Breast Programs, as well as director of the Surgical Breast Oncology Fellowship Program here at the Cleveland Clinic. If we could advance the slides, Dr. Valente will introduce our expert panel to you.
Good evening. Thank you all for taking the time out of your busy day to join us. I want to introduce our esteemed panel, our multidisciplinary panel, among a bunch of other physicians here at the Cleveland Clinic.
Dr. Valente, there you go. You weren't
hear me?
showing on your camera.
Oh, okay. So Dr. Julie Rittner is a breast radiation radiologist here at the Cleveland Clinic. She completed her fellowship in women's breast imaging at Brigham and Williams Hospital, and she served as staff member there for 10 years before joining us at the Cleveland Clinic. She is the fellowship director for breast imaging here at the Cleveland Clinic. Dr. Raza Hoda is a breast pathologist at the Cleveland Clinic. He completed a cytopathology fellowship at Mass General, followed by a breast pathology fellowship at Memorial Sloan Kettering. Dr. Zara Alhili is a breast surgeon here at the Cleveland Clinic. She joined in 2016 after completing both a breast surgery and endocrine surgery fellowship at Mayo Clinic. Dr. Stephen Bernard is a plastic, reconstructive, and microvascular surgeon at the Cleveland Clinic. He completed general surgery residency and plastic surgery fellowship training at UPMC, and he is the plastic surgery residency coordinator. Dr. Andrew Vassell is a radiation oncologist at the Cleveland Clinic. He completed his radiation oncology training at the Cleveland Clinic and is the radiation oncologist head at Strongsville Breast Center. Dr. Megan Cruz is a medical oncologist here at the Cleveland Clinic, and she completed her residency at UPMC before coming to the Cleveland Clinic for her hematology oncology fellowship. Thank you to our team for joining us this evening.
So all of the participants tonight in the audience are not going to be able to speak. You will be automatically muted. However, we are very interested in your feedback and questions. So you will be able to share your questions via the chat function. And so if you have questions, please put those in the chat section. If you already submitted your questions at the time of registration, we do have those questions, and we will try to get to as many of the questions that we can tonight. I hope this will be informative, and we'll start with just a little general information about the various specialties, and following that, we will get to as many of the questions as we can. So just a little bit about our Cleveland Clinic breast cancer program. We provide high quality screening, diagnosis, and treatment of breast cancer, or for patients who are at high risk for breast cancer. We have multidisciplinary teams with members such as you see tonight: medical oncology, surgery, radiation oncology, plastic surgery, pathology, imaging, and beyond that, social work, medical genetics, and others. So, tonight we're really going to be focusing on the basics of breast cancer, and then if we have time, we can talk a little bit about clinical trials and patient support services as well.
So without further ado, let's get started with the questions. So if the panelists want to go ahead and turn on their videos. Welcome. So the first question is going to be for radiology. Dr. Rittner, what can someone expect if they have an abnormal mammogram and they're contacted and asked to come in for additional imaging?
So when a patient is recalled from their screening mammogram, it can be a number of different things. We basically usually just need to get some additional imaging. So it usually starts with some additional mammogram views. Often when you come in for a diagnostic mammogram, which is for those extra special views, we usually get a 3D mammogram at that time if you haven't already had one. To better evaluate the area that we're questioning. And often it can usually be resolved with just some additional mammogram views, and the finding, we can determine whether it's a real finding or whether it's just summation artifact and something that we're not worried about. Often then patients will have an ultrasound as well, depending on what the finding is on the mammogram. Sometimes we'll also add an ultrasound to get a better look at the finding and to determine if we need to do a biopsy or if it's just a cyst that we can let go and put the patient back to screening. So usually the diagnostic setting would involve some additional mammogram pictures and sometimes an ultrasound.
Thank you.
Thank you, Dr. Rittner. Dr. Ahoda, moving on to pathology. So if a patient does have an abnormal mammogram or a lump in the breast, oftentimes if it's suspicious appearing, a biopsy will be done or the tumor will be removed as part of breast surgery. Can you talk to us a little bit about both your end of things, how you receive this specimen, what happens in pathology, and also just briefly walk us through a typical pathology report and what kind of things you're looking for when you look at a cancer under the microscope?
Certainly. Thank you for having me again. So essentially, we can start with the biopsy first. Corneal biopsies, as Dr. Rittner mentioned, these are small portions of the tumor that we try and look at to assess. These samples get processed in formalin, so it takes some time for it to get fixed before we actually take a look at it in the microscope. Oftentimes, this can be a delay. We usually recommend 6 to 72 hours of formalin fixation before we actually even look at the specimen. When we do look at the specimen, we try and see number one, what we have, and number two, if it answers the question that, for example, Dr. Rittner has. There's an archival distortion or there's a mass, and we try to look to see if there's an explanation. Sometimes the explanation isn't evident, so we'll have to do levels because this is an actual piece of tissue that's embedded in wax. And so we have to do levels to make sure that we are actually seeing an appropriate representation of what was biopsied. Sometimes these are atypical proliferations, and they require stains to sort of classify its lineage or to classify if it's invasive or in situ, benign or malignant. And these stains can take some time and also some time to interpret. So there's sort of various stages that we go through. Number one, are we dealing with a cancer? And that's my number one goal, is that when someone gets a benign report, I want it to be 100% sure that it's benign. When I'm making a diagnosis of invasive carcinoma, I want it to be 100% sure that it is invasive. And those things do take time. And we do have a quality assurance practice here where we do show it to another pathologist, first-time malignant diagnoses, and that's to ensure that a patient who does get a diagnosis of invasive carcinoma does indeed have invasive carcinoma. When it comes to then the subsequent samples, an excision from Dr. El-Hili or a mastectomy, these are much larger cases, and that also does require to be fixed before we do sample it. And again, it takes about 6 to 72 hours to get fixed, and then we sample it. And we have pathology assistants who are very good and very well trained, who sample the lesions, who sample everything that was viewed on mammography, for example, or MRI. And we try to assess every nodule that was seen. And also representative areas of background breast. We also have house staff who are training here at our institution, and they also do examine the gross specimens, is what we call the excision specimens. And we go through those with our trainees, and we ensure that all the lesions are well sampled. And then when we get those blocks and we get those slides, we want to make sure that we're actually, again, answering all the questions that we're seeing from Dr. Ritter or from Dr. El-Hili, for example, here. Are we seeing the lesions that were, or Dr. Valente, sorry, I see there's another surgeon here. Are we actually answering all the questions that we're seeing clinically? And all those things, we may have not accurately sampled everything, or we may want to see more of a lesion. So those all take time. But again, my ultimate goal is to see everything that was seen on imaging or seen clinically before the surgery. And we want to answer all those questions. We want to make sure that no stone is left unturned, and we want to appropriately stage our patients. Hopefully that was the pathology in a nutshell, if everyone is wondering.
Great,
That was
thank you.
great.
Okay.
Thanks, Dr. Hoda. So a patient comes in, they have an abnormal mammogram, they get a core needle biopsy, and they get the call that they're diagnosed with breast cancer. The next step is for them to be scheduled to see a breast surgeon. So Dr. Al-Healy, a patient comes in to see you in the office. Can you walk us through that consultation and how you help the patient determine what type of surgery is appropriate for them?
Thank you. And thank you all for joining us. So if we do have a biopsy that shows a diagnosis of breast cancer, what would happen at that point is the patient will be booked to see the multidisciplinary team. And the multidisciplinary team consists of the surgeon, the medical oncologist, radiation oncologist, the plastic surgeon, the genetic counselor if needed, and additional people as well that are part of the team, for example, our psychologist as well. Some consultations are determined as needed, and some consultations are determined as the baseline, and that's usually with the surgeon, the medical oncologist, and the radiation oncologist. So what would happen in that visit is that we would review all the imaging that occurs before the patient would come into their appointment, and also all the pathology that we receive. We also determine at that point if we need to do any additional imaging or any additional biopsies. So in terms of surgery is one of the most important parts of the treatment for breast cancer. And once the surgery allows us to remove the breast cancer, any additional treatments come in to help us prevent the cancer from coming back. So in terms of surgery, the two main options are a lumpectomy, which means we're removing the cancer and a rim of normal tissue. And the other surgery is called a mastectomy, which means we're removing the entire breast. So the lumpectomy and a mastectomy are two surgeries, and there's a lot of conversation about, is a bigger surgery better or is a smaller surgery enough? And certainly based on a lot of studies that looked at thousands and thousands of women, there is no data that shows us that a bigger surgery is necessarily better. As long as somebody is having all the treatment that is recommended, the survival, the outcome from this breast cancer is very similar between the two surgeries if one is suitable for both. So how we decide about suitability is that we would take into consideration the size of the cancer. Is it in one spot? Is it more than one spot? We'd also take into consideration the location of it, the extent of it. So where is it lying? How much of the tissue needs to be removed? And also things like the patient's breast size. So if you can imagine a larger cancer, if we're removing that from the breast, that would require us to remove a large area that would cause a change in the shape or the size of the breast. However, if a woman has a larger breast and we're removing a smaller or even a little bit larger cancer, then this may be closed up in a way or closed at surgery in a way that would not cause a big defect or a big change in the shape or the size of the breast. So those are kind of the two big surgeries. When we talk about mastectomy as well, there are options of having reconstruction or no reconstruction. So no reconstruction means going flat, and a woman can wear a prosthetic inside her bra to create a breast shape and clothes, or a reconstruction, which means building the breast. And Dr. Bernard will talk to us more about that as well. So when we take these things into consideration, we also talk to the patient, and I'd like to get the patients involved in the decision as well. I'd like to see what the patient's thoughts are, what would they like to achieve in this, for their surgery. So these are more important things to keep in mind. Other things to keep in mind are the patient's health. Do they have any other medical issues? Are they suitable for the surgery that we're intending to do? For example, if we're talking about doing a mastectomy with some reconstruction, then we would be more concerned if somebody has a smoking history or is diabetic, as some of these patients that have these histories might have a worse outcome compared to somebody who doesn't have that. So what would happen in that conversation is that we talk about these risk factors as well. So that is kind of surgery in a nutshell. One more thing I'd like to also mention is that there is a chance of doing a lumpectomy in a way that we can also remove a large area from the breast in a woman with a larger breast and still be able in that sense to do a breast reduction at the same time. So that is one option that is kind of an in-between a lumpectomy and a mastectomy with the reconstruction. Certainly with a lumpectomy as well, there's options for paying, we always pay attention to the cosmetic outcome of the breast, and we do that whether it's a lumpectomy or a mastectomy or a lumpectomy with reduction. So this is an important conversation as well to have with your doctor about the outcomes that you'd like to achieve.
Thanks, Dr. El-Hili. So Dr. Bernard, as Dr. El-Hili indicated, the plastic surgeons work very closely with the breast surgeons. Can you tell us about the different types of reconstruction and plastic procedures that are done for breast cancer patients?
Absolutely. So I guess I will start out with when we do something called an oncoplastic reduction. Dr. El-Hili had just mentioned that. So if someone has a breast that's large enough, often it can be treated better if we can do the lumpectomy. The radiation therapy can be more effective. If we can make the breast smaller, lift the breast at the same time, and still get out the tumor with an even wider margin than we might otherwise use with a typical lumpectomy. So that would be probably the first part where the plastic surgeon enters in. And most of the time, the breast surgeons, such as Dr. El-Hili or Dr. Valente, we work so closely together that they have a good idea of what type of surgery would be appropriate for the patient. So they kind of start the conversation for me. And then when I see the patient, what I try and do is present all the options, which is kind of answers what you're saying, Dr. Moore, in that what I will do is start with the simpler and kind of go to the more complex. And the types of reconstructions we do kind of fall into two buckets. One is to use an implant, and the other is to use your own tissue, which for most cases means using your belly. And there are advantages and disadvantages to each one of those. And just to hit those highlights very briefly, and I'd be happy to expound on those for anybody further. But from an implant standpoint, there's no other area of the body that you have to heal from. That makes it simpler. It takes quite a bit less time to do the surgery, and the recovery is simpler. The downside of an implant is that the implant is there. Some patients don't tolerate implants well, and some people really aren't appropriate for an implant reconstruction. So the other way is to use your belly. And there are ways that are kind of in between that, but just to keep the this early part of the conversation fairly straightforward. When we use the belly, we're using what we would normally get rid of from a tummy tuck. This isn't exactly accurate, but this gives you an idea. And we make a breast out of that. And we usually do that under a microscope. And the procedure itself takes us on the order of about 8 hours per side. And then you're in the hospital about 3 days. And then with a lot of follow-up, we can do revisions and make things look better. But the real advantage there is it's your own tissue.
Great,
And that
thanks, Dr.
pretty
Bernard.
well covers what I do.
Thank you.
Next up is radiation oncology. So Dr. Bassel, can you walk us through radiation, a radiation treatment, and why do we give radiation?
Sure. Like the other doctor said, a lot of what we do involves discussing our cases with each other and figuring out what the patient's interested in and a lot about their disease. So, starting with imaging, looking at what imaging has been done, what the results are, talk to the surgeon about what surgery options are there for the patient, looking at pathology to understand what type of disease it is and, what extent we might be thinking about radiating, talking to medical oncologists to see what are their plans, how are they going to sequence their therapies, and also plastic surgeons if a patient is going to have a reconstruction or a reduction surgery and how that may play a role into how we're going to approach a person's case. So we really try to meet with patients up front and gather all the information and have everyone talk to each other in a multidisciplinary clinic so a patient can understand what their options are. So Probably one of the most common things we do is after lumpectomy, we provide radiation after lumpectomy. And what radiation is, most of the time it's a high energy X-ray or electron. And do it first with imaging, so we do a CT them for treatment. We then design the treatment on a computer with software. We have them come back in. They're repositioned the same way they were repositioned for their scan, and then we deliver the treatment. The treatment itself is, I tell patients, it's very boring. You don't see it, you don't feel it, but eventually you'll start to notice that there's side effects to it. And it really depends on to what extent we're doing radiation, and that is going to be really influenced by a person's disease characteristics, and also patient factors. Could be things like age and other medical problems. You may be focused just on the area where the tumor had originated. You may be doing a treatment to the entire breast. You may be doing a treatment to include lymph node areas. We do treat patients after they've had reconstructions. And the goal of doing radiation is really to catch what can't be seen. Imaging, it's great, but it's not perfect. It doesn't see things at a microscopic level. And so what we want to do is treat the area where the cancer originated to prevent it from recurring, so that we don't end up with problems down the road with the person's breast cancer. So that's radiation, I'd say, in a nutshell. It's very it's technical stuff that we do. We're sitting at a computer designing a lot, and we've got the physics. I say in physician, we have to study physics to do this, but I love it.
Dr. Moore, you're muted. Dr. Moore, you're muted.
Sorry about that, everybody. Thanks, Dr. Vassal. Dr. Cruz, could you tell us a little bit about medical oncology and what the role of the medical oncologist is, what we mean when we say systemic treatment, the types of systemic treatments that are available, and how we decide what to use with whom?
Of course. So thank you. The field of medical oncology, the name sort of gives it away. The things that Dr. Moore and I do for our patients are really prescribing the medications that go along with cancer care. And these can really fall in multiple different buckets. The one that most people are most familiar with is chemotherapy, or sort of IV treatments that go throughout the whole body. And actually, all of our therapies tend to go throughout the whole body, making them a little bit different than the treatments that you've heard about so far that may be more directed to the breast and lymph node areas. So with chemotherapy, I think a lot of people have heard that that's a tough treatment, that it kills both good and bad cells. And we don't take the decision to give chemotherapy lightly. We select the patients based on a lot of the information from our team members. So that would include the patient's stage, any imaging information we have, and then certainly the pieces of information that Dr. Hoda gives us on our pathology reports that really are roadmaps to tell us which treatments are best for which patients. And I'm sure we'll get into that more detail later on tonight. So there's chemotherapy. There's also a variety of targeted therapies, and those can include therapies that are pills directed against the female hormones, so estrogen and progesterone. There's also a special target on a number of breast cancers called HER2, and we have a variety of targeted medications that target HER2. And our field continues to grow. We now have medications that are targeted against BRCA mutations. We have medications that harness the power of the immune system. And the goal of all of these medications is to circulate throughout the body and kind of get to cancer cells wherever they may be. For our patients that have stage 1 through 3 breast cancer, the goal of these therapies is really to help cure and to try to get rid of those cancer cells so our patients can go on and live normal lives. We also spend a lot of time talking with and treating patients who have stage 4 or metastatic breast cancer. And these are patients who may present to us when the cancer has already spread to another part of their body, or have been treated for breast cancer in the past and then unfortunately have the cancer come back in another part of their body. And when that situation occurs, medications are generally the best way to get at wherever that cancer is, because that process usually happens by cancer cells traveling in the blood. And because these medications get into the blood, they can go to wherever the cancer cells might be. So I know that there are a lot of questions on this topic that we'll cover over time. It's really a very personal decision as we talk about medication. So not only are there cancer-related factors that we think about, but we also have to take into account a patient's overall health, their other medical problems, and also their goals for themselves. Sometimes we give really toxic medication knowing that we want to do absolutely everything we can to get rid of a cancer. And then there are times where the toxic effects of that medication may actually take away from a person's life, both quality and length of life. And so these decisions are made with a whole team in mind that includes the patient and their family members.
Excellent. Thank you all for kind of that bird's eye view of how you play a role in helping someone with their journey through breast cancer. So we're going to kind of narrow it down to some of the questions now that a lot of the questions that were put in when people signed up for this event. So starting with Dr. Rittner, breast density. Can you explain what it means to have breast dense? Why does it make imaging difficult? And how do patients know what their breast density is, and how do you make recommendations based on that?
Okay, that's a great question. So breast density refers to the mixture. So every breast is made of a mixture of fatty tissue and fibroglandular tissue. And the fibroglandular tissue is dense or white on the mammogram, and the fatty tissue is gray or more transparent on the mammogram. So everybody has a mixture from all the way from a predominantly fatty mixture all the way to an extremely dense mixture. And this is really important because the denser your breast composition becomes, the harder it is for us to see fine calcifications or masses until they're more extensive in the sense of calcifications or larger in the situation of a mass. So it can mask a significant finding until it's larger or more apparent. Whereas if somebody has a completely fatty composition of their breast tissue, we can see a very small mass, 3 millimeters. We've diagnosed, 3 millimeter, 4 millimeter cancers because it's very easy for us to see in that fatty tissue. So it's very important for a patient to know their breast density, and there's a lot of national conversation about this. It's been going on over the last decade. And the reason why it's important is because some patients with dense breast tissue may choose to have additional supplemental screening to basically pick up, more additional cancers that mammography can miss. There's no imaging test that's perfect. They're all complementary. So some patients think that the ultrasound is the better test because they have dense breast tissue, and that's not true. There's cancers that'll definitely be seen on the mammogram that will be missed with the ultrasound, and the converse is true. So everything is complementary in breast imaging. And so it's important that you talk with your doctor as to whether you want any supplemental screening, and options for supplemental screening would include ultrasound and MRI. Those are sort of the two supplemental screening tools that we have. And so it's something that you could talk to your doctor about to see if one of those adjunctive tests would be, helpful to pick up an additional breast cancer. And the way that a patient would know if they have dense breast tissue or not, there's actually state legislation. So every patient receives, when you receive a letter in the mail, it will let you know if you have dense breast tissue or not. And for patients, we divide it out into dense or not dense. And it just has to do, to be qualified as having dense tissue, the breast mixture is greater than 50% of that white fibroglandular tissue, 50% or more, to be classified as dense. And the other thing that I would say is that if you have dense breast tissue, we offer a 3D mammogram. It's been in use in the United States since about 2010 regularly. And that's a really great tool, mammographic tool, to see through that dense breast tissue and pick up cancers when they're smaller and more clinically treatable. So I would recommend a screening 3D mammogram, especially for patients with dense breast tissue, and possibly supplemental screening.
Great,
That's great. Thank you. So moving along to other questions, and again, please feel free to put your questions in the chat, although we have plenty of questions from your registration as well. Dr. Hoda, we had questions about the difference between the grade of a cancer and the stage of a cancer. Could you explain that, please?
Certainly. Both grade and stage are prognostic factors. So prognosis means, how likely you are to survive, X number of years. When it comes to grade, we are specifically talking about the essentially the ugliness of the tumor. A low-grade tumor looks very similar to benign breast and behaves in an indolent fashion, generally speaking. More higher-grade tumor can look pleomorphic, or that means that the cells don't resemble at all really benign breast tissue, and they look very, very ugly, to say another word. And we divide that on a 3-scale basis. It goes from low nuclear grade to intermediate to high, and essentially that forms basically on corneal biopsy sort of an idea of what kind of tumor we're dealing with. Staging we generally reserve for excision specimens, or from a radiographic standpoint, we can sort of get an idea of how widespread a disease is. And again, like grade, it sort of can tell you how aggressive or indolent a disease can behave. Like Dr. Rittner had mentioned, she diagnosed she found a 3-millimeter focus of invasive carcinoma. That carcinoma would be of low stage, but it can be a very aggressive, ugly-looking tumor caught very early. Stage incorporates not only the size of the tumor, so we have cutoffs ranging from 5 millimeters as a cutoff to greater than 5 centimeters. So that is basically the tumor stage. Then you have the nodal stage, so how many lymph nodes are involved and how large the extent of those involvements span. Is it greater than 2 millimeters? Is it coming out of the lymph nodes? Is it involving distant lymph nodes? And then is it involving further distant organs like the liver or the lung? And those would be all factors that go into this stage. Again, you can have a low nuclear grade tumor that's behaving badly because of one reason or another and can have a high stage. Either it was clinically indolent and grew for a very long time in an insidious fashion and spread. And you can have a high nuclear grade tumor that's a very low stage. But both fall into the sort of realm of prognostic data that I'm sure you use in the medical oncology and radiation oncology realm in order to plan your treatments.
That's great. Thank you.
Dr. Alhili, question for you. So Dr. Hoda had mentioned stage for breast cancer. And so the size of the tumor plays part of the stage, but also looking at the lymph nodes. So you had mentioned talking about the options for breast surgery, but we also do surgically check the lymph nodes. Can you go over how we do that for surgery and how we determine how many lymph nodes need to be removed?
Yes, that's a very good question. So as part of our breast surgery, we also stage the breast cancer by checking the lymph node status. So to start out with, when we obtain imaging before the patient sees the surgeon, when they're having their initial diagnosis, we do check the status of the lymph nodes by imaging. That means by taking pictures using a mammogram or an ultrasound. We're able to identify if there's any abnormalities in the lymph node, and in some cases, we would decide to obtain another biopsy of the site to see if there's any concerning features in the lymph nodes. When we're planning for surgery, when we talk about testing the lymph nodes to obtain a stage, what we mean is that we are checking the first draining lymph nodes. These lymph nodes are called sentinel lymph nodes. So how we do this is we inject a dye. It's a radioactive dye that fades from the body in about 24 hours, and it travels like a map to the lymph nodes, and it sits in the first lymph nodes that drain the breast. And these could be 1, could be 2, could be 3, could be of a different number in every person. So when we do the surgery, we use this dye that travels to the lymph node, but sometimes we also inject a blue colored dye that also travels to the lymph nodes. And we use these two techniques to identify these sentinel lymph nodes. And we remove them. When we remove them, we get them checked under the microscope, and we use that information to decide if we need to remove any additional lymph nodes. If the lymph nodes are negative, we do not remove any additional lymph nodes. However, if the lymph nodes are positive, we use that information to decide if we need to clean out more lymph nodes and do a procedure called an axillary lymph node dissection, or is the information we've obtained from the sentinel lymph nodes enough? So even in patients that do have some positive nodes, not in every case would we need to clean out the lymph nodes, but there's certain criteria that we need to take into consideration, like how they came in with their diagnosis, what did the imaging show, what are we finding, the extent of it, the size of the cancer, the extent of the metastasis, the extent of the metastatic area in the lymph node. That information we use to decide if we need to do an axillary dissection, which in some cases it is needed and it is the standard of care. If somebody comes in with a positive node at their diagnosis, that is a time where the recommendation would be that we need to clean out the lymph node pocket. That is called a lymph node dissection instead of doing a sentinel lymph node at the time of surgery. When we have a patient that comes in with a positive node, sometimes we take into consideration different features or factors of the tumor, and we also discuss with our medical oncologist to see, is there some type of treatment that we can give, a systemic therapy treatment that we can give to shrink down the lymph nodes. And sometimes we're able to use this treatment to shrink down the lymph nodes, and when the lymph nodes shrink or melt away, we're able to clean out all the cancer that has been sitting in the lymph node. And by that, when we go and do our sentinel lymph node biopsy after receiving this treatment, like chemotherapy, for example, when we remove it, if the cancer is no longer found in the lymph node, then we do not need to clean out any more of the lymph nodes. So that information is useful to decide what are the next best steps when somebody is diagnosed with breast cancer.
Thank you.
Thanks. Dr. Bernard, we have a question about how long implants are meant to last, breast implants, and also do they need to be replaced after a certain amount of time routinely or only if there are concerns? And you'll have to unmute.
Excellent question that everybody has that is going to get implants and everybody should know about. Implants themselves are made, every implant, whether it's saline or so-called silicon, they're all made with a silicone rubber shell. So they're all made out of silicone. The silicone is very tough. If you jumped up and down on these implants, they would not break. These are really meant to last. That being said, the FDA has determined that these devices should be considered 10-year devices. That doesn't mean that they need to be replaced at 10 years. It just means that everybody ought to go into having an implant with the understanding that at some point in the future, they may need to have that implant replaced. If someone goes and it's been 10 years and they're not having any problems with those implants, they haven't had a radiologic study or an ultrasound or something like that that shows a break in the implant, those implants can be in forever. There is no reason to take out an asymptomatic implant that's intact. If there's any kind of a problem, or if a study is done for other reasons, an MRI is done, and incidentally, which means a finding that is, found, wasn't really being looked for, but found. So if the finding is that the implant is broken, we recommend that that implant be replaced. The implants, to go a little further into that, the implants that we have now, this is actually about the 7th generation, and they've gotten better and better each time. When an implant breaks, it generally breaks because it forms a fold, and that fold rubs on itself and eventually weakens it. It's actually pretty rare. And at this point, for most people, the implant rupture rate, if you follow people out 10 years, is 5% or less.
Thank you.
On to radiation oncology. So Dr. Bassel, you see a patient in consultation for radiation oncology. Can you go over how you determine how many treatments a patient needs, the dose that they're going to get, and kind of their extent of treatment? Can you walk us through that?
Sure. A lot's going to depend on what type of surgery they're going to have. And it can also depend on a person's breast size. So, and their disease biology. So there's a lot of things we have to factor in. A common scenario though is a lumpectomy, and the trend now is to use smaller and smaller radiation fields for favorable biology disease. So sometimes we'll use 5 radiation treatments directed just at where the tumor had originated. When we're treating the whole entire breast, or it could be a more advanced disease, or it could be an issue where we're concerned that there's other areas of the breast that might have a higher risk of involvement. We're often doing about 3 weeks of treatment. And then if you're treating lymph nodes, now you're getting to even bigger fields. So a big way you can think about broad strokes about radiation is the bigger the area that you're treating, the slower you want to go. So these smaller, shorter courses are usually higher dose per treatment, but fewer of them, a smaller area. If you're treating a bigger area, let's say a person has lymph nodes that are involved and you want to treat lymph nodes that are really hard to get to surgically, could be between ribs, underneath muscle. We're usually going very slow, and that could be 5 to 6 weeks of radiation. Same thing when a person has a reconstruction, we're usually going very slow. You can think of it as, you're treating a bigger area. That's usually 5 weeks of radiation. So a lot has to do with the area you're treating and also the disease biology. That's the way we're thinking about it.
Thank you.
So Dr. Cruz, we have a lot of medical oncology questions. I'm going to put 2 together for you. One is about genomic testing. What is it and how is it used to determine the course of treatment? And also, what is an oncotype, which is a very specific type of genomic testing? Would you be able to address those?
Sure. So when we think about genomic testing in general, what that means is that we're looking at cancer DNA or cancer genes. And so some of our audience may be familiar with the concept of genetic testing, and those 2 concepts, even though they sound very similar, are actually pretty different. So when I think about genetic testing, I'm thinking about patients who are being tested for particular DNA changes that they may have inherited from their parents that lead to a risk of developing a cancer. And of course, in this situation, developing breast cancer or any other cancer that might go along with it. So that is often information that we know before a patient starts into their treatment, but can be picked up at some point along the way. For genomic testing, we're again looking at DNA, but looking at more specifically the cancer DNA. And you'd be surprised that this can be different, and actually is different than the DNA that you have in the rest of your body. It's actually what makes the cancer behave differently and escape the normal controls that your body would put on cells that are abnormal and should die off. In the cancer cells, they're abnormal, they should die off, but they don't, and that's because they look different. So when we talk about genomic testing, there's genomic testing that helps us to determine treatment for patients who are being treated with the intent to cure. An oncotype falls into that category. You may also hear of other tests like MammoPrint that intend to do the same thing. And the idea behind these tests is they give us another sense of cancer biology or cancer behavior. So we know that the markers that we get on the pathology report, estrogen receptor, progesterone receptor, and HER2, take us so far about telling us about behavior, but it doesn't get us all the way there. We know that there are cancers that should behave in a good way, meaning they shouldn't grow quickly, they should be highly curable, but then they ultimately do come back. And so tests like Oncotype or MammoPrint, they're designed to look at those cancers that should behave well, but are destined to behave badly, and find them sooner so we can increase the intensity of a patient's treatment when we still have the potential to cure. So when I'm thinking about genomic testing for my patients with stage 1 or stage 2 breast cancer, those are largely going to be patients that have cancers that fall into the bucket of hormone receptor positive and HER2 negative disease. These are patients who wouldn't ordinarily get chemotherapy off the bat. Many of our HER2 positive and triple negative breast cancer patients, chemotherapy will be routinely recommended for them. So those tests are really designed to figure out who with hormone positive breast cancer should get chemo and who will have a great outcome and a good chance of cure without needing chemotherapy. So these tests have gone a long way to help us figure out who needs to take on the risks of chemotherapy and who can get by without it. There's also the concept of genomic testing for metastatic disease. And so here we are taking samples sometimes from the breast, sometimes from the organ that the cancer has spread to, like the liver or the lung. We can even get cancer DNA in the blood. And the idea here is to look for targets for treatment. So those may be standard targets that we already have FDA approved treatments for. So things like I mentioned before, BRCA mutations being a great option. There's also some information we can get there that will tell us if a cancer might be sensitive to immunotherapy. And then there are a growing number of clinical trials that allow for patients with particular types of DNA changes. And these may be trials that are specific to breast cancer. They can also be trials that actually include patients of a variety of cancer types, but all with the same basic DNA changes. So it really depends on which situation you're talking about when you talk about genomics, but important for both early stage and advanced breast cancer.
Thanks, Dr. Cruz. So let's walk through this. A patient gets diagnosed with breast cancer, undergoes surgery, radiation, systemic therapy, and then they're put into this category of breast cancer survivor. So Dr. Moore is one of our breast cancer survivorship leaders. Dr. Moore, can you walk us through what does it mean to be a breast cancer survivor? What does that look like? How do patients get followed? Kind of a big question.
Yeah, so that's actually a big group of people because really anybody who's had a prior diagnosis of breast cancer, whether they have active disease or whether they have have all signs of cancer removed and are just living with the aftermath, are breast cancer survivors as long as you're alive following a diagnosis of breast cancer. So that looks in many different ways. So often when we talk about survivorship services or survivorship clinics, we're focusing less on the active treatment issues and more on the long-term effects of treatment once intensive treatment, surgery, chemotherapy has completed. And some of those people are on chronic or maintenance type treatment, such as the hormonal treatments. Some are on no therapy. And some of those people may even be living with advanced disease, but it's behaving in an indolent manner and is not requiring as much intensive treatment. So with survivorship programs, we really try to address the other health issues that might come about as a result of those treatments. We want to address quality of life issues that may be a result of those treatments, or especially the side effects of some of the hormonal treatments that is more of a long-term treatment for many individuals. And then also lifestyle behaviors. What can we do to not only maximize our outcomes with respect to the breast cancer, but our overall health outcomes, particularly since some of our treatments may adversely affect cardiovascular health or other aspects of health. So we can focus on healthy diet and exercise and other things that can be done to try to mitigate some of those effects.
Great, thanks. And going along with that, just some statistics for the participants. So 1 in 8 women get breast cancer. So a 12% lifetime risk of getting breast cancer. And 85% of women who develop breast cancer don't have any family history. So for a lot of these women, a breast cancer diagnosis comes, as a shock. It really changes the trajectory of their life, of the stressors, of their, kind of what they were going through. It puts a significant pause. So the panelists, how do you walk patients through this? I mean, this is a very emotional time in their lives, and they reach out to a lot of us, starting with the diagnosis, ending with survivorship. What do you guys recommend, or what do you tell patients? What's out there for this type of emotional support for the patients and for their families?
I can get started with that, and then we can get our other team members. So when the patient comes in, there's a lot going on. There's a lot of anxiety getting a diagnosis of breast cancer, coming in, having to face, the diagnosis. What is it about? What to do? There's just a lot of stress there. And certainly coming in, what we would do is we try to also send some information about these early days, some information, connect you with the teams. And when a woman or a man is diagnosed with breast cancer, they would usually hear from our team member, our care coordinators, our nurse coordinators, who can link them as well with services before they even come in. So when the patients come in and we discuss the diagnosis, I think one of the main things is getting all the information would allow one to feel like they're more in control. And I think that's a very important thing. When you start learning more about what's going on and start making decisions and have a set plan, I think that is a very big step forward in terms of, just getting to terms with a diagnosis and what needs to be done. It's important to have a support system around you. It's important to have, family, friends that are supportive as well. And we have services at the clinic that we can provide to our patients. So first of all, we have a psychology breast service. We have some great breast psychologists that see specifically our breast cancer patients, or even our breast patients in general who have or do not have breast cancer or have a high risk for developing breast cancer. And our psychologists can work with our women in terms of talking about the diagnosis, dealing with the diagnosis, talking to other people, and they can be given different tips and tools and things that they can do to minimize this anxiety and stress that comes with the diagnosis. Another thing as well is we have also social services and some other support groups. We have a support group such as the Gathering Place, a mentorship program where we link patients with other patients to learn more about the diagnosis and their journey. And these are some important things that we do for our patients as well. And also just one thing to add is that if you feel that there is something that you wish to ask about or that you need to connect with, we can always help you with these services as well.
And I would just comment that those emotional needs and coping with your diagnosis extends far beyond the first few days. It extends into your early treatment period, extends into the survivorship period, and the needs and the stressors change over that period of time. It's really not unusual for me to see a patient who, feels like they're doing well and they have it all together, and then all of a sudden it just hits them. Maybe it's a year into treatment, or maybe it's 6 months. It's really different for everybody, but I think those points always come. And, it has a lot to do with how you feel about yourself, how you feel about your health, how you fit into your family life. Sometimes our family members and our friends don't really know what to say when it comes to a cancer diagnosis. And, we as your breast cancer team can really help to put those pieces in place, give you some of the words to talk to your friends and family about this. And I think we also have a wonderful team of social workers who see our patients who are going through medical treatment or not, to process some of that, because it can be hard when our family members are our greatest cheerleaders, but you also may just want to have a down day here and there. And how do you manage that? So our social workers, our psychologists, us, this team that you see in front of you, these are the things that we deal with day in and day out. And a lot of patients share those same struggles with us. So I think being open about it and talking about it is really the best thing you can do. And then also finding outlets for that. So TOSIC has a number of programs for taking care of yourself in other ways. So art therapy, music therapy. We have massages and Reiki and other things available that may be helpful to think about your health or your life in a different way so that it doesn't all become about the cancer. And that's really, really important as you go through this process.
Those are really great insights. Thanks. I'm going to change subject a little bit, although this has a little bit to do with survivorship. Dr. Rittner, once somebody has undergone surgery for breast cancer, they are typically recommended to have continued monitoring of some sort for new breast cancers or for local recurrence of their cancer. Can you talk a little bit about what the imaging recommendations are after either a lumpectomy or after various types of mastectomy, and with or without reconstruction?
Yeah, thank you. That's a great question. So once a patient has been fully treated, they usually present to us annually for a mammogram as the starting point for their screening. So we still recommend annual mammography to screen patients for either a recurrence of their breast cancer in their treated breast, or for a new breast cancer that may show up elsewhere. And so that's really the first step in monitoring patients, whether they've had a lumpectomy or in patients that have had a mastectomy. It's often a misconception that if a patient has had a mastectomy, that they don't need to have any imaging on that side anymore. And it really depends on what type of a reconstruction you've had. So if you've had a mastectomy with no reconstruction, so the chest wall is flat, then it's pretty easy and accessible to examine for any new, very small changes. So in a patient that doesn't have any breast tissue, we can't do a mammogram, and we often just recommend clinical exam, and then we would ultrasound if there's any new lump or areas of concern. If a patient's had a mastectomy with an implant reconstruction, there's just a very thin layer or envelope of native breast tissue. And it's usually just skin and a very thin layer of fat. And then the implant is either in front of or behind the muscle, but it's really pushing out that very thin layer. So similar to when a patient has not had any reconstruction, there's just a very thin layer of tissue. So the patient and their physician that's following them annually can easily clinically examine the breast and notice any small lumps. There's not really enough breast tissue for us to examine with a mammogram. But if there's any clinically lump that you or your doctor may feel, we would always start then with an ultrasound to further evaluate that. The patients that we recommend still have an annual mammogram are patients that have had a mastectomy with some type of a tissue flap reconstruction, because there's native breast tissue, a very thin layer of native breast tissue all around where the mastectomy was, and then the tissue flap, which creates the breast mass. And so we can image that with mammography, and we're looking for very small areas of recurrence right around that tissue envelope and at the posterior aspect. And so in patients that have had a mastectomy with a tissue flap reconstruction, they should be having an annual mammogram still for screening on that side. So some patients occasionally will get MRIs as well, but that's really that's up to the referring physician. These patients are often followed in our high-risk medical breast clinic or by our breast oncology colleagues, and they usually determine whether they think that's an important adjunct way to follow the patients as well.
Thank you.
So speaking of mastectomy, sometimes there's a trend that a lot of women come in asking about bilateral mastectomy. So they get diagnosed with breast cancer and they come in and they say, remove both breasts because they think that improves their prognosis or their survival from that breast cancer. Dr. Alhili and Dr. Bernard, can you talk about, Dr. Alhili first, maybe when removing both breasts is indicated, if it's indicated, and then Dr. Bernard, how you would approach, somebody who's interested in why they would remove both breasts. Dr. Alhili?
Thank you. That's a very important question that we get asked a lot. So removing the healthy breast is also called a contralateral prophylactic mastectomy. And really the main indication for this, if it, is if somebody is considered high risk or they have a genetic reason for developing breast cancer. For example, if a patient has a BRCA1 or BRCA2 mutation, these would be the main indications. However, without these medical indications, a lot of patients that would choose to remove the healthy breast choose it for reasons of fear of recurrence, for having to continually follow up, and also for achieving symmetry, and that is trying to achieve the same breast shape and size and location between the right and left side, and that is called symmetry, to try to match them. So those would be the most common reasons. So if we look at women that have it not for a genetic reason, we don't have any data that shows us that removing the healthy breast improves anybody's survival in any way. There's some things that I would also usually like to discuss is that removing the normal breast would require additional surgery, so that's additional surgery time. Some other things to take into consideration is that there's risks for surgery. So surgery doesn't come without its risks. So when we remove the breast that has the cancer tissue, the cancer diagnosis, we can have risks of things like an infection, bleeding, bruising, reconstruction issues. And when we're removing the healthy breast, we're increasing that risk because we're removing additional tissue that might also get risk factors for complications after surgery. So that's an important thing to discuss and to consider as well when making your decision and choice about it. Sometimes developing a complication or a problem after surgery can lead to a delay in getting your next treatment plan. So I think that's also another thing to consider when you're making a choice about if this is necessary or not. As we've discussed, there's a little bit touched on about genetic risk. So just to get some information about that, most women develop breast cancer not for a genetic reason. The genetic causes are about 5 to 10% of women would develop a breast cancer due to a family history or a genetic reason. And these are women that could derive a benefit or get a benefit from removing this normal tissue.
Thank you.
From a reconstructive standpoint, I think Dr. Alhili hit the most important points kind of going into thinking about it. And largely the decision is made by the time they've hit my office. So the decision has been made by either the patient or, usually a combination of the breast surgeon with the patient as to whether it's going to be unilateral or bilateral. So then when it comes to me, I'll just give you some of the, my thoughts about unilateral versus bilateral. Dr. Alhili is absolutely right in that it really is literally twice as much surgery. So the complication rate doesn't quite go up, doesn't quite double, but it does go up significantly. And if you look at an implant reconstruction and you look at everyone that has an implant reconstruction, the complication rate is somewhere on the order of about 10%, where it might be significant. So if you kind of ballpark it and say you've doubled that to 20%, that is 1 in 5 patients. So it's important to take that into consideration. Having said that, though, I will say that from our standpoint, there is sort of an ideal breast size and shape, and most people simply don't have that. And if you have that, then doing one side, the reconstruction can look pretty much like the other side without doing anything. For the rest of people who really don't fit into that category, and again, that it really is most people, we have to do something to that opposite breast to make it match. In this case, when we do the same type of mastectomy on each side, we can usually get a very good match between the two sides. Things that go into consideration are the size of the breast. Small breast can sometimes be easier than large breasts, and we might do something like reduce it. But another thing to consider is that, particularly if we're using, if you recall back to what I was saying earlier about using your own tissues, and we use the belly, we call that autologous, which basically means using your own tissue. You really only get one shot at doing that. So if you were to develop a cancer in one breast and you came in and you said, well, I want the other breast removed and I want to use my belly for a reconstruction, then we can go ahead and do that. If you go and you have that belly used for a one-sided reconstruction, you can't go back later and use the rest of the belly to help do that reconstruction. So those are some of the considerations from my standpoint.
Thank you. I'm going to switch gears a little bit and ask Dr. Cruz to talk about hormonal treatments for breast cancer. Could you explain the different commonly used hormonal treatments such as aromatase inhibitors and tamoxifen, a little bit about the side effects and why we give these and who would benefit from them, and then even if you have time, a little bit about how to manage some of those side effects.
Yeah, absolutely. So oftentimes when I'm talking to a patient who has a hormone positive or had a hormone positive breast cancer, so those that are either ER, estrogen receptor, or PR, progesterone receptor positive, they are surprised when I say that actually the most important part of their treatment from a medical standpoint are these anti-estrogen pills rather than chemotherapy. I think a lot of people come in thinking that cancer treatment really relies on chemotherapy, but if you look at these two types of treatment pound for pound, for a hormone receptor positive breast cancer, the anti-estrogen treatment is actually more important, to the degree that it actually almost cuts in half your risk of a breast cancer recurrence in the breast, in the lymph nodes around the breast, or somewhere else in the body. So we're actually getting kind of multiple bang for our buck with these treatments. They can also actually be helpful if you have intact breast tissue in preventing future hormone positive breast cancers. So it's really important to be on these, and it seems pretty easy, right? You take a pill for a certain number of years. Sometimes that's 5, sometimes that's 10. It depends on the patient. But I think the devil's in the details. So there's a lot here that we have to take into account. Tamoxifen is an old medication that we use for both pre and postmenopausal women. So your menstrual status is really important. For women who have either had their uterus removed or maybe had a uterine ablation, there's other ways for us to figure out if the ovaries are still working. And that's actually really crucial because the other type of anti-estrogen pill, the aromatase inhibitors, these are drugs like anastrozole, letrozole, or exemestane. These really only work when a woman no longer has estrogen production from her ovaries. And sometimes we actually make it such that a woman doesn't have estrogen production from the ovaries in order to give them these medications. And that's really for our higher risk young premenopausal women. So a lot of things that go into deciding on which of these treatments is appropriate. In general, though, premenopausal women are going to be recommended to get tamoxifen, unless they're very high risk, in which case we might talk about giving the postmenopausal medications, the aromatase inhibitors, in combination with a medicine to shut down the ovaries or actually physically take the ovaries out. These medicines also not only have a difference in who you can use them in, but have a difference in side effects. So sometimes that's how we make the decisions. In general, I would say that menopause-like symptoms, things like hot flashes, changes in mood, changes in sexual desire, drive, function, those are going to be pretty common between both types of medication. Important key things to think about is that tamoxifen actually acts like an estrogen in certain places in the body, not on breast cells or breast cancer cells, but on bones, for example. And so it can be really good for women who have early osteoporosis or bone thinning. Tamoxifen can actually help us build the bones back up. But it can also have some dangerous long-term side effects, which are really rare, but patients should know about them. And those include the risk of blood clots, both in the legs and in the lungs, and also the risk of uterine problems, specifically uterine cancers, which often scare patients. You know, why would I take a medication to prevent one cancer if it causes another cancer? And in many times, the benefits of the medicine really outweigh the risks. But again, this is something that, you know, you should be getting into with your doctors about where does that balance lie and what can we do about it. For the aromatase inhibitors, we have to watch bone health very closely on these medications. The more we take estrogen away, the harder it can be on the bones. And these aromatase inhibitors often tend to cause more general muscle aches, joint aches, stiffness when you first get up in the morning or if you've been inactive for a period of time. So this is where we really dive into what medical conditions does each patient bring to the table? What are your fears about medication? As we said, these are medicines you're often on for years rather than months, so getting it right over the long term matters. And because these side effects span a huge gamut, we're often checking in with our patients very frequently, a few times a year. There's lots and lots of ways to manage side effects. There's medications and environmental things you can do about hot flashes. We have great colleagues in the gynecologic department that can help us with sexual function issues, whether that's vaginal dryness or discharge or sexual function issues. And then, of course, mood issues. As we said, this is a stressful time, so adding that on top of changes in your mood can be really, really hard. Exercise actually tends to help with a lot of these things. So you'll hear us say that very frequently. It's good for your health and it's good for tolerance of your medications. But again, we really want to work on the side effects of medications because staying on these anti-estrogen pills, it's really the longer the better for most women. So we may take some time to figure it out in the beginning just so you can stay on it and have it be as tolerable as possible in the long run.
That's great. Thank you.
Speaking of long-term side effects, this question is going to be for radiation oncology. So, Dr. Vassal, a lot of times women present with an early stage breast cancer. Small mastectomy really is kind of overkill sometimes as far as removing a small cancer. So, when a patient's considering a lumpectomy, one of the things that they're really scared of these, your beams that they can't see, so to speak. So a lot of patients have concerns about, is radiation toxic to the heart, to the lungs? What long-term effects does it have? And can they receive radiation more than once? Can you go over how you explain that to patients?
Sure. Like you said, our therapies definitely can hurt people. And so we have to be very careful in how we do it. A place like the Cleveland Clinic, we're very focused on heart and heart health. And I tell all my patients up front that, we're going to worry about your heart, but you also need to as well. So making sure they're taking care of their things like diabetes, if they're smoking, to try and quit smoking, blood keep the radiation to a minimum. Things like partial breast radiation to try and avoid the heart. But when you're treating the breast, and then especially when you're treating the internal mammary lymph nodes, it does become more challenging. So that's where different techniques come into play. So there's different ways you can angle radiation beams, block out the heart to minimize dose to the heart. Sometimes it's a way of positioning a person. You may position them prone, so on their stomach, and let gravity pull breast tissue down and away from their chest wall. Probably the most extreme and technically challenging, but doable for many patients, it's what's called deep inspiration breath hold. So there's technologies that we have for a patient to be able to monitor their breathing during treatment. So if you imagine taking a deep breath in that's comfortable, what you're doing is you're inflating your lungs and you're pushing your heart back and down away from where we want to treat. And so that's one of the ways that we can manipulate someone's anatomy so that we can focus the radiation to the breast and avoid their heart. So that's, I guess, in a nutshell, the things that we are doing is different techniques and limiting how the amount of tissue that we're radiating to try and avoid cardiac complications. Same thing with lung. There's ways you can angle, shape, block out lung, move the fields to avoid parts of the lung. Some things, the lung, especially when you're treating patients who are node positive, the apex of the lung is just the way we're built as human beings. The very apex is going to get a little bit of radiation. Usually it's asymptomatic. Over the years, I've seen a handful of patients who have temporary issues of the lungs getting irritated by the radiation. Usually happens a few months afterwards, called pneumonitis. And I tell all of my patients that I'm a lifer and I don't plan to leave the Cleveland Clinic. I love it. I love the team that we get to work with. And if they do have issues, to always know that they can call me. And I'll do whatever I can to help mitigate whatever is going on. But I think it all very much starts up front in trying to design treatment to be as safe as possible from the very beginning. And I try and walk patients through how we do it, why we do these things, really demystify it, so they understand what are the risks and why we're doing this and what we're doing to mitigate risks up front.
Thank you. I have a question for Dr. Hoda, our pathologist. One of our participants asked whether you consider ductal carcinoma in situ, or DCIS, to be cancer. And related to that, what is the difference between DCIS and LCIS?
Certainly. So DCIS, ductal carcinoma in situ, is a form of a cancer. It's not invasive, but it's in situ, meaning that it's within the ductal system. It's a malignant process. It certainly has a predilection to spread through the ductal system, and has a capability or the propensity to break through that barrier and invade into the actual breast tissue. So when we diagnose someone with DCIS, ductal carcinoma in situ, essentially what we're saying is that this is a disease that needs to be cut out, removed surgically, and then subsequently not only to treat that disease, but also to ensure that there is no invasion. And as our medical oncologists know, Dr. Moore and Dr. Cruz, that these patients do sometimes also get hormonal therapy, depending on its ER status. We sometimes also radiate, depending on how close it is to the margins. It can be very finicky because there isn't really sometimes a mass. It can just be sort of and so Dr. Rittner would know that, these are sometimes insidious diseases. They sometimes have calcifications that can give us a hint of how widespread it is, or it can be really just a non-mass forming insidious process. So these are very tricky. The counterpoint to that is the difference between ductal carcinoma in situ and lobular carcinoma in situ. Lobular carcinoma in situ, it's much like DCIS, is an in situ form of disease, but it really rests on the I guess the philosophical definition of what a carcinoma is. The way I like to think of it, and I'm sure you guys as well, it's more of a risk factor than a disease itself. We here at the clinic do operate on lobular carcinoma in situ. We'd like to remove it because it is there. It is a mass sometimes. But it is also not only a disease, but it's also more of a risk factor. And it's a risk factor for, first of all, contralateral disease. So patient, the evidence of lobular carcinoma in situ has implications for bilateral disease. And like DCIS, has the propensity to be associated with invasive disease. There are various forms of lobular carcinoma in situ. There are pleomorphic types or classic types. Classic type is one that I like to think is more indolent. That is also insidious, so it can take over the entire breast. It can be, small mass forming. And pleomorphic type lobular carcinoma in situ is much like DCIS, and that needs to be removed. That has to have clear margins. And those are more high grade and have the propensity to be associated with invasive disease. Both are forms of carcinoma, and both have the propensity to be associated with invasive disease. But really, again, depending on its nuclear grade, I think we touched on grade, we do grade ductal carcinoma in situs, and I did mention the two types of lobular carcinoma in situs. These all have different sort of prognostic variables that are associated with them. High grade DCIS that has necrosis in the middle of it, that is, has a large span, is more likely to be associated with invasive disease, which is why they need to be removed in general. And so whenever we make the diagnosis of either of those diseases, we like to see if there's any, microinvasive, so meaning a small foci of invasive carcinoma, or macroinvasive, a large focus associated with it. Hopefully that answers the question. Let me know.
Thanks. And then just to follow up on that, Dr. Healy, how would you approach differently DCIS versus LCIS? And somebody, for instance, that had an abnormal mammogram, had a biopsy, and that small sample showed one of these lesions.
Mm-hmm. It's a very good question. So just to kind of simplify as well how we're going to talk about it, DCIS is stage 0 breast cancer. So we treat it like breast cancer. When we remove it, we're considering the extent of what we need to remove, whether it's a lumpectomy or if it's an extensive area of DCIS, whether we need to do more extensive surgery like a mastectomy. Then we need to consider other treatments like the anti-estrogen medication, the anti-hormone medication, or radiation therapy as well. These are things that we need to consider for additional treatments for DCIS. For LCIS, this is not stage 0 breast cancer. As we discussed, this is a risk factor. So we use that information to further decide. So in somebody that does have a breast cancer already, our management is based on the breast cancer that they have. But if a patient ends up having a biopsy that shows LCIS, those abnormal cells called LCIS, then what we would use this information to decide about their risk. So we would look at different factors in terms of their personal family history, their biopsies, their breast density, and use all of these to calculate their risk. And when we do that, we would identify that women that have LCIS would be considered at a higher risk of developing breast cancer compared with somebody that does not have LCIS. So when a woman reaches this high-risk stage, they would then fit into a category where we should watch them more closely. For example, that would entail more additional screening. So in addition to the annual mammograms, a woman would benefit from additional screening like an MRI. So that would alternate every 6 months so once a year, and then would alternate with the mammogram. And then some additional things is to discuss the benefit of using medication to cut down the risk. And certainly medication such as tamoxifen has been shown in many studies to cut down the risk of breast cancer in women have LCIS and atypical cells. So that would be the most important difference. And if that is found on a biopsy, in some instances, we'd need to excise around this area so that we can make sure that there's no other abnormalities sitting within that location. And then one important thing to mention is that we have a medical breast clinic. Our medical breast clinic is a specialty of providers that would see patients that are high risk. Our medical breast providers would do a risk assessment, and they would identify if patients would need to be followed up more frequently going forward.
Thank you. So you guys were kind of touching on high risk, early stage breast cancer. Let's flip it a little bit. There are a lot of women that have metastatic breast cancer. So Dr. Cruz, can you go over how does somebody get diagnosed with metastatic breast cancer? What does that mean? What does survival look like for somebody living with metastatic breast cancer?
Yeah, so this is a question that has a number of parts to it. I would say, just like our conversation about early stage breast cancer, the way that women present can be very different, and then the treatment options they have really depend on the biology of the cancer. So, to start about how women present, you might be a woman who comes with a mammogram detected breast cancer, and this is not super common, but occasionally the cancers are more advanced when they're found. And if there's a large mass in the breast or multiple lymph nodes under the arm that we can detect, your medical oncologist might recommend that you have scans of your body before you enter into any of the treatments we've been talking about that really target the breast. And if that happens, there's a small but real chance that we might find cancer that has spread somewhere else, even if a patient has no symptoms. So that might be one way we find it. I would say that the more common way is probably with someone either with a breast cancer history or without, who develops an odd symptom, something that they can't really make sense of, that their doctor might evaluate. Say this is cough, shortness of breath, abdominal pain, a bone pain. Any of these things can happen. And then when we go on to have further evaluation, usually with imaging or with blood tests, we might find an abnormality that leads us to be concerned about cancer. And then a patient may undergo a biopsy, a needle sample of, instead of a breast mass, a mass somewhere else that would give us a diagnosis of cancer. And actually under the microscope, our pathologists like Dr. Hoda can actually tell us that this are cancer cells that have come from a breast mass rather than from some other organ in the body. Every cancer cell has kind of its own fingerprint that way. So once we know that this is a breast cell that has ended up somewhere else in the body, that's really when a patient gets this diagnosis. We again find out those key 3 features, the estrogen receptor, progesterone receptor, and HER2. And then that's where the medical oncologist will come in to talk about what the treatment options might be. And those pieces of information also help us to determine prognosis or life expectancy for patients. And when we talk about life expectancy in this situation, it's all averages and numbers that come from large population studies of thousands of women. When we're talking about an individual woman, it's really hard to know. And again, there are other medical problems, where the cancer is, how affected their organ function is by the cancer. These are all things that contribute to what we can expect that cancer will do over what period of time and what treatment options they have. So our treatment options for metastatic breast cancer patients, again, can be anything from pills to standard old IV chemotherapy. Really depends on where the cancer is and what it's doing at the time. Patients often worry that once we find out that they have metastatic disease, that the prognosis is very short, meaning that they may not be here days or weeks or months from now. Thankfully, in breast cancer, while that does happen, many of our patients go on to live good quality lives on the order of years. And again, that's not what everyone achieves. That's what we're going for with new treatment options and with clinical trials. But we can usually tell our patients that they will have some good quality time ahead of them. And then this is where we get into that conversation about what's important and how do we get there. So this is a very personal conversation, but I think the biggest thing is to realize that there are treatment options available, often many treatment options. We had, greater than 10 drug approvals in the last couple of years across metastatic breast cancer. So we're always learning more. It's always changing. And so I would encourage patients, even if you get a diagnosis like this, and it seems like there's not going to be good options on the table, please at least have a conversation with a medical oncologist to see what options might be out there, and to help kind of plan what the future will look like.
Thank you, Dr. Cruz. We're running short on time, but I'm going to ask you one last question. Since you mentioned clinical trials, we've had a lot of interest in a vaccine trial that we've just opened, and people are wondering who is eligible. Obviously, we are ultimately hoping that this would be a vaccine that could prevent breast cancer, but this is an earlier stage trial. Can you share with us who's eligible and a little bit more about that trial?
Yeah, definitely. So we're excited about the vaccine trial too. And so what this vaccine trial is, it's being run by one of our oncologists, Dr. Budd. He's the lead investigator on it, although all of our medical oncologists can enroll patients onto this study. And right now the trial is looking specifically at patients with a history of triple negative breast cancer who had either stage 2 or 3 disease within the last 3 years, meaning their diagnosis has been in the last 3 years. And they've completed all of their intended treatment, meaning surgery, radiation, and any medical therapy that might be recommended. So all the things you've heard about today. And then the idea is that patients will receive a series of vaccines directed against a particular protein that is known to be found in triple negative breast cancer cells, but not so much in the normal breast or in normal tissues of the body. And so the idea would be that it could potentially stimulate the immune system to attack these breast cancer cells wherever they are, or prevent abnormal ones from developing. This study is in its earliest phases of investigation. It's called a phase 1 study. So this is where we're really looking at the dose of the vaccine that's going to be safe, not so much the effect of the vaccine. And phase 1 studies tend to be very small. So this is actually a study of only 18 patients. We hope that it will have broader implications in the future for patients that may not fit those tight criteria that I just told you about. But for right now, a small select group of triple negative breast cancer patients, and with more to come.
Thank you. And then I think we have a few more slides that Amanda's going to help bring up. Thanks.
So as these slides get pulled up, I want to thank our panelists for and our participants for sharing your time with us tonight. Here at the Cleveland Clinic, we really value and believe in a team-based approach to treating breast cancer and managing survivorship. So, as you meet your team, with your family, there are also a lot of other cancer support services that our team has touched upon throughout the community. We don't have enough time to go over everything, but just to kind of go over our medical breast services. So these are women, who have women in their family that have breast cancer, who are considered high risk for developing breast cancer, following with our medical breast team. A lot of community outreach. For younger women who are diagnosed with breast cancer, we've got a young women clinic, and that's, talking about fertility preservation. Just because you have breast cancer doesn't mean you're not able to have children in the future. So talking about that, and going along with that for, women, just sexual health. How do you deal with that and manage that during treatment and after treatment? And then importantly, our breast cancer survivorship clinic. Next slide. So these are just a bunch of services. This is a great screen snapshot for anybody who's interested in learning more about this. What's offered here at the Cleveland Clinic, that we can offer, rides to and from appointments, financial support, kind of the breast health and wellness, how to eat right, weight maintenance, stuff like that. Next slide. So how can you help? So spread the word about our program, our patient services. We have a Fourth Angel Mentor Program, and I want to just take a second to make a plug for this. So this is almost like a big sister, big brother program that we have. Most patients don't know somebody who's going through breast cancer. And so this is a program where there are patients who have, are breast cancer survivors a few years out, who want to kind of share the experience, what it's like to sit in a chemo chair, what it's like to undergo surgery, And so these are women that we kind of match up with a new breast cancer patient. So they talk to them on the phone, they kind of give them some tips and tricks that, you know, as physicians, we don't know about. So it's a really great program that we offer patients. Obviously, opportunities for donors and to schedule appointments. So if you're not already a Cleveland Clinic patient and you're interested in learning more about any of the services, we do offer second opinions. So, you know, here's a number to call. There's a website as well to reach out. We'd love to help. So if you want to find out more information about our breast program, it's www.ccf.org/breast. And with that, we're going to close. So thank you to all the panelists. This session was recorded, so it will be eventually available on the website, as long as looking at some of these questions that have been put up to see if we can answer any questions as well.
And thank you all for your attention.
Have a good night.